This is Nathan Radcliffe, and I am pleased to present a case of a placement of the CyPass Supraciliary Stent after cataract extraction. You see we have removed the cataract, placing the intraocular lens right now, and the case would be indistinguishable from any other cataract surgery up until this point. This surgery is performed at the New York Eye Surgery Center, where I'm fortunate enough to have a retrobulbar block placed for most patients undergoing any type of intraocular surgery. I've tilted the patient's head 35 degrees away from me, I've tilted the scope 35 degrees towards me, and I have a great view of the angle. I can see the trabecular meshwork here with some blood reflux, and I can see the ciliary body face. This would indeed be an ideal candidate for placement of the CyPass because all of the angle structures, even the scleral spur, ciliary body, and trabecular meshwork are clearly visualized. I've introduced the CyPass and its inserter into the eye, and I'm choosing a location 1 clock hour superior to the nasal, or in this case 3 o'clock position. This is to avoid the vascular plexus that can be directly nasally. I've placed the stent into the supraciliary space. I have a little bit of blood reflux here, but I can still see the scent, and I have good visualization still. I will use a cohesive viscoelastic such as Provisc to push away some of that blood to further clarify how many rings on the stent I can see. And I can see 3 rings here, so I'm going to push in a little bit more. I can now see just the outer ring, really at the level of the trabecular meshwork. Nothing is close to the corneal endothelium at all. As you can see, the bleeding really was quite trivial and is quickly removed. All bleeding looks bigger under a gonioscope. So we've got the blood out of the eye, removing any excess viscoelastic, and we're going to have good flow day 1 and low pressures day 1 here, so we want to remove the viscoelastic, but we don't have to go overboard. I keep the eye pressurized and hydrated so that I don't have relative hypotony, which might allow more blood into the anterior chamber, and as you can see here, no bleeding, great case, and we're finished.